already told her. Bhavna, we can go ahead. Yeah.
Hi, Shanti.
Good evening, madam.
Already told her.
Ma'am, we are live now and we can start the meeting.
Yes, you can start.
Yes. So, good evening, respected faculties and delegates present over here. On behalf of Corona Remedies, I, Bhavna Verma, welcome you all for the Code Connect live webinar of AMOG's Medical Disorder Committee with Trichy, Dindigul, Theni, Kanchipuram OG societies. So, I would like to first welcome Dr. Anit. Dr. Anit Kumar is MSOG, Consultant Infertility Specialist at Sri Kumaran Fertility Center. Please welcome Dr. Anit. I would request you to further take over the session.
Very good afternoon to all the delegates and speakers and esteemed seniors logged in today. So today is the first webinar of the series that we're going to have continuously every alternate Wednesdays. And so I'm very happy to start the series today. And for the first speaker, I'd like to I'd like to invite Dr. Sneha Madam, to give the welcome address and start the Kuttu Velakam. So introducing Sneha Madam is such an honor to me. Sneha Madam is, currently the AMOG's chairperson for medical disorders. Madam is the managing director of Shukrita Hospital Maternity and Surgical Hospital with over around 30 years of experience in the field of obstetrics and gynecology. Madam has held various leadership programs throughout of Foxy career from starting from 2007 to 2008 being the president Yogs, and then Madam has held the chairperson press committee Foxy 2019 to 21, governing council number of ICOG, currently chairperson medical disorder of AMOG's 22 to 24. Madam has numerous talks and publications to her
Thank
award.
you.
And yes, Madam, and various awards.
Thank you, Dr. Anit. Thank you for that kind introduction. A very good evening to respected Sir Dr. Prakash Trivedi, Chief Guest for today's function. Guest of honor, Madam Jayam Kanan, our dear friend Dr. Bhaskar Pal, all the faculties here, Dr. Sudita Tandulwadkar, and of course our AMOG's president, Dr. Rajendra Singh Pardesi, who is always there with us and he's always present for every program. Today he is busy in some function. Madam Sujata Dalvi, the secretary of AMOG's, Madam Sunita Tandulwadkar, all the esteemed faculties, panelists, chairperson, and the president secretaries of Trichy, Theni, Dindigul, all the societies here from Tamil Nadu, our dear friend Dr. Charmila, the expert for this panel discussion. I welcome all of you here for this wonderful program, especially based on the endoscopy. As Madam Jem Kanan has rightly said, what a gynecologist, the beginner should know. That is how we're going to start this program. And I'm sure all the faculties will do justice to the topics, and of course, the delegates will be benefited. I welcome all of you once again, and thank you all the Tamil Nadu societies for being associated with us. I, Dr. Sneha Bhuya, take this opportunity to seek your blessings and humbly request you to nominate me and vote me for my candidature as Vice President Foxy from West Zone for the upcoming elections. Once again, I thank all of you, and over to you, Dr. Anit. Thank you so much. Bhavna, you can post Sir CV and we can go ahead with the...
Ma'am, can we start with the prayer?
Yes, I will. I invite all the respected dignitaries for the lamp lighting and invocation.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Over to you, ma'am. Dr. Anit.
Yes, let us pray God and have blessings from our respected seniors. Thank you so much, respected Dr. Prakash Trivedi, for accepting our invitation to be the chief guest for today's program. Sir is a very well-known figure, not only in FOXY, but also is our IG, and I'm sure all of you know him. But without much ado, we would like to listen to his precious word. With your busy schedule, sir, you have taken out time for our program, and definitely we want to get blessed by your, of course, listen to your precious word. Over to you, sir.
It's such a great pleasure. Sneha, most of you don't know, though Chayam Kanan's madam's birthday will be during our AGL. I and Sneha Buriyar have the same birth date, 17th February. So both of us are Aquarian. Praful Patel also was born on the same day. And the phase of Aquarian is very good, Sneha. You don't worry. You will win. So there is absolutely no problem.
Thank you.
But I am so happy that there is a beautiful program on endoscopy part, especially with Trichy, Dindigul, Tenni, and Kanjipuram OBGYN Society, and humbled with 30 years of experience in endoscopy in various organizations. Of course, 1st to 4th, we have the AAGL in June. All of you register for that. I think so. The speakers you have and the panel you have is really outstanding. So I am 100% sure that everybody is going to enjoy the learning. And my age is not to bless anybody. I can only just support somebody or stand by somebody. It's the age may look, may not look. I don't know. But what I'm trying to give an idea is there's nothing like blessing. We all are friends and colleagues. So always support for all of you. Wonderful. I see a lot of ladies except Bhaskar. And of course,
Anit.
Sunita and all the others, all are our good friends. It's an honor to be part of MOX program, especially with Sujata Dalvi being there. Incidentally, the president is not there, but I think so scientific things has to keep moving, and it's such an honor and pleasure. I will be listening to most of the part of your talk, but I will leave all the time for everybody to speak on the subject and share their interaction. Thank you very much.
Thank you so much, sir. Age is just a number, but the stature where you have reached, definitely you are an inspiration for all of us. And that's the reason you worth blessing us. Thank you, sir. Thank you so much. Bhavna, I request you to, post the CV of the guest of honor, Dr. Chayam Kanan first, and then Dr. Bhaskar Pal. Yeah. So it's my pride and privilege.
Tamil Nadu.
Yes,
Yes.
madam.
Yes.
I
Tamil
would just
Nadu
say,
knows me very well, Jayam.
yes, madam. Thank you so
Yes.
much. Bhavna,
Yes.
you can stop sharing.
Yes.
Madam, yes, definitely.
Yes.
We request you, we don't need to request you. You are always blessing us all the time, I would say, and we are so humbled and blessed. Definitely, we would like to listen to your words of wisdom and guidance for us.
Thank
Over
you,
to you,
Sneha,
madam.
for this wonderful meeting you have done with Prakash Trivedi as the top person. I have been seeing his AAGL programs. I have been participating in it from 2015, every alternate year. And it is a pleasure to see him doing that conference in the same venue with the same set of people, and he is going so constantly. That means his ideas are always, as he said, everything is constant. None of you need to worry, as I see many of the faces here who are upcoming for the next better post, big post in Foxy, and do the best to everybody. For Prakash, probably the International Association president, you have not been there, that should be the one that he has to get it. And I wish every one of you, greet every one of you for the best of your efforts. And Prakash and Sunita know how we are interrelated to each other without even seeing Sunita. What Prakash told me in 2015, I took it as a word and we carried. Later on, I came to know who is Sunita. Like that, our friendship goes on. And everyone here is a wonderful endoscopist, be it a senior or junior. Prakash Trivedi may do it just like that as a child. Others may take it very seriously. But at the end, every one of you, I know, is showing success in your field. This year, the success should be for Sneha, then Umaya,
Thank you, sir.
then the great Sunita, my greatest friend, and the coming year for Bhaskar Pal. And with us, I say greetings to all of you.
Thank you so much. Thank you so much, madam. I would like to request Dr. Bhaskar Pal, who is a dear friend. And of course, Bhaskar, everyone knows him as a very excellent academician, I would say, a past vice president of Foxy and immediate past president of IAG. And Bhaskar, we would like to listen to you, of course, your precious words. Bhavna, you can stop sharing.
At the outset, am I audible?
Yes,
Yes.
Bhaskar.
Yeah, at the outset, my sincere thanks to Dr. Rajendra Singh Pardesi, President of AMOGS, Dr. Sujata Dalvi, Secretary General of AMOGS, and my dear friend Sneha, Chairperson of the Medical Disorders Committee of AMOGS, for inviting me in such elite company. Prakash doesn't like to be told old, but the fact is that Prakash has been one of the pioneers of endoscopy in India. And when we were doing our post-graduation, from that time, Prakash started his endoscopy, and we saw that. And he's a person who's trained people immensely. But what is two great things about Prakash is that the way he supports younger people and the zeal that he has even now for teaching and training people. While Dr. Jayam was saying, I think Prakash was telling us something very important the other day, that what seniors took years to learn, these days the younger generation learns in months. And we must propagate training in endoscopy far and wide, because if you look at Foxy has 39,000 members. Our Endoscopy Association, IAG, has only around 4,000 members. So I think more people need to do endoscopy, and such programs will go a long way in encouraging people to do endoscopy. And for younger people, they pick up endoscopy much faster than we did. I welcome the Tamil Nadu societies, namely Dindigul, Theni, and Kanchivaram and Madurai, to this program. And I'm sure that it will be a great program. I also take this opportunity to wish all the best in the coming elections to my dear friend Sunita, my dear friend Sneha, and my dear friend Umayyan. Thank you very much. And we have an excellent talk on TLH and on hysteroscopy, and a panel on difficult situations on laparoscopy. I would urge all of you to become members of IAG and to attend the landmark historic AAGL Global Congress. We have been lucky to get it second time in India. We do not know when it will come the third time. But this is a once in a lifetime endoscopy event happening in India. And we'd like to see all of you in large numbers. Thank you very much. Thanks again, Sneha.
Thank you so much, Bhaskar. Actually, Dr. Pardesi is not present today, but his blessings are always with us. And everyone, even from Tamil Nadu, knows a very helping hand to all the youngsters upcoming for, working for any organization for that matter. With this, I welcome and request Dr. Sujata Dalvi, who is the Secretary of AMOGS, a very humble human being, very supportive and always there for all of us. Almost present for all our programs, encouraging us, supporting us. So, madam, we would like to listen to, we will we'd like to listen to you and have your guidance. Over
Thank
to
you,
madam.
Sneha. Yeah, thank you, Sneha, for such kind introduction. At an outset, on behalf of AMOGS as a secretary of AMOGS, I would like to express my gratitude to our AMOGS president, Dr. Rajendra Singh Pardesi, who is always an encouraging force behind any scientific session as such. I would also like to express my gratitude to AMOGS Medical Disorder Committee Chairperson, Dr. Sneha Bhuya, for arranging such lovely scientific programs. I would like to acknowledge the presence of our chief guest, Dr. Prakash Trivedi, and his words of wisdom, and also our guest of honor, Dr. Jayam and Dr. Bhaskar Pal. All of them are expert in the field of endoscopy. Today's topics are such that I'm sure all those who have logged in and all those who will be attending, they will be learning a lot, and they will know how simplified the endoscopic surgery would be if you follow the right steps. And I would like to wish all the best wishes to all those who are fighting for the elections for FOXI for their future endeavor in FOXI. Thank you so much. Thank you.
Thank you so much, madam. With this, I thank all of you, all the respected dignitaries, Dr. Prakash Trivedi, sir, Madam Jayam Kannan, our dear friend, Dr. Bhaskar Pal, all the esteemed faculties, the speakers, and amongst office bearers, Dr. Pardesi, sir, and Madam Sujata Darvi, Dr. Sunita Tandurwadkar, and of course, the convener, Dr. Umayal, the coordinators, Dr. Anit and Dr. Shobhana, all the president secretaries of the Teni, Trichy, Dindigul and Kanchipuram societies. I would like to express my gratitude, and with this, we would like to go ahead with the scientific program. I thank all of you once again. Thank you so much. And over to you, Dr. Anit and Dr. Shobhana, for further proceedings.
Thank you all the seniors for those wonderful words of wisdom. So moving on to the scientific program, so I like to invite our chairpersons for the webinar today, Dr. Shanti Rani Madam and Dr. Lakshmi Prabha Madam. Dr. Shanti Rani Madam is a professor HOD of Teni Medical College, and she's a well-known person among our Tamil Nadu societies. Madam is a very eager and very warm person to talk to, and we all enjoyed talking to ma'am. And she has contributed so much to the academic forum in Tamil Nadu. Next, I'd like to invite Dr. Lakshmi Prabha Madam. Lakshmi Prabha Madam is consultant OB-GYN of Rana Hospital and Maruti Hospital in Tiruchirappalli. Madam is currently the secretary of Trichy Obstetrics and Gynec Society, and Madam is editorial committee of Triox Journal. Madam has held various leadership positions in FOXI, and Madam's field of interest is high risk obstetrics and gynecology. I like to invite the chairpersons to introduce a speaker for today, Dr. Sunita Tandulwakar, Madam.
Thank you, Ali, for your kind words. Can we have Madam CV, Sunita Ma'am CV?
Okay, don't play the CV. Instead, let me get an opportunity to talk to
Madam actually doesn't need any introduction. And we have been all inspired with the Eagle project, Madam. And Madam is present time head of the department and chief in IVF endoscopy center at Pune. And extraordinary achievement. It's India's first stem cell baby and world's first at the age of 45. Which happened on 16th April 2018. Madam was the past president of Pune Obstetric Society and shows
Shanti Rani, that's okay. Thank you so much.
Madam, I'll read one or two things. Icon of the year 2022 endoscopy and Best Citizen of India award. And she had letter of appreciation from the President of India in 2012. Thank you, Madam. A lot more you are having. But you have inspired us juniors all with your lectures. We used to hear your lectures continuously in all AACOG. Thank you, Madam. I invite you for your talk.
There is one line introduction for Sunita.
Yes, yes, ma'am.
Unstoppable Sunita Tandurwadkar.
Okay. Unstoppable, unbeatable.
You know what, Shanti, thank you so much. And it was so lovely to see Lakshmi Prabha after maybe 6 to 8 months. I had been to all of you. To Jayamala, I was 3 days ago. Lakshmi Prabha, I was 6-8 months ago with Jayam. I missed
in Trichy that time. Anit, we keep on meeting at the airport when he's stressed with his baby yet to come out. And Shanti Rani, you are the head of the department. Umay, always talking to her in the morning also when she told me ki at 4 p.m. I said, I'm with Sneha at 4 p.m. She said, I'm the convener, madam. And Prakash Trivedi, the one-line answer. Kyo Jayam? Jayam is my spiritual friend, guru. She is my strong supporter. In thick and thin, she openly supports and I appreciate. And another is Prakash. She is my, I don't know, he calls me younger sister. Elder brother bolne ko kaisa to bhi lagta hai. He is not elder. He is younger than any one of us. As far as his stamina of working and tremendous intelligent brain, amazingly intelligent, creative, mastermind. And his conferences are out of the box, and it's always honor to be a part of his every program. Prakash, thank you for being always there with me. Actually, let me take 1 minute to explain. Many don't know who taught me how to organize the conference. Charu Bape keeps on telling Pune is known for Dagdu Shet, Halwai Ganpati, Bakarwadi, and Sunita's conferences. Prakash Trivedi in 2002 installed my IVF center at Ruby Hall, and he said, Sunita, it will be with the bank conference, simplifying infertility, if you remember, Prakash. And I said, conferences I never organized. He said, I'll guide you. He sat with me, he made my scientific program, he helped me to generate the funds, and my first conference on my shoulder was 2002, and that was the mentor, Prakash Trivedi. Prakash, whatever the conferences of any extent I will make, I will never forget our 2002 journey. Thank you always being with me. And let me go, friends, with the topic. I was told that you don't give too many of a complicated surgery. Try to be more with the, everyone will learn from your lecture, make in that way. So, friends, let me start here. The hysterectomy is the second most commonly performed, up to the extent that now we got a government putting an audit on our hysterectomy. So naturally, it is the cesarean first got criticized, and then now the hysterectomy. I'm going to tell you all 7 steps towards a successful TLH. Maybe it be a simple or may it be complicated. First most important thing is a surgeon. Discipline in a surgeon is a mandatory if they want to excel as a surgeon. Forget only endoscopy. Sound knowledge about the anatomy as well as the equipments. It's very important. Routine inspection of the instrument equipment for any malfunction. You know, we cannot just rely on a biomedical person or the ward boys and the sister. One should have their own habit of inspecting your instrument. And most important thing is don't crowd your operation theater and don't crowd your operation trolley. You should know for particular operation over the period of 3 decades in an endoscopy, you land up in having ligashure, you have a RB, you have a thunderbeat, you have a harmonic, but don't keep all these machineries around the patient's table. You should know for particular case, what is the energy source I need? It may be sometimes only bipolar and monopolar. You don't need a crowding of those instruments. And second thing is on a trolley. You don't need to keep trolley full of so many instruments. It is important for us to understand that it is not the instrument which makes the surgery successful. It is wise use of these few instruments by the surgeon makes the surgery successful. Now, preparation and position, please give tremendous importance. Today, we operated 126 kg, previous 3 cesarean. Very important for me to give a positioning of these patients, because we know the long-term thromboembolism and other complications. So this legging, I know these are expensive, but what is important to know is after, even if you are doing with the simple legging, which we all have done in our early part of our endoscopic surgery, ensure that your thigh is not hyperextended, hyperflexed, or externally rotated. Same is take care of a popliteal fossa. It should be well padded. It's important. Now, next important thing, what happens is we usually cover the patient's upper part, and then the anesthetist is struggling. This is how I enroll the hand inside, so that we just don't allow the cautery burn. In my life, it has not happened, but I have heard 2-3 of my friends who have, even at Ruby Hall by the surgeon. So it's important that you learn with the other's mistake and improve, because it can happen with you also. So I fold the hands and keep it so that it is not having any pressure in the axillary fossa. Second thing is cautery burn, you protect. But at the same time, if you keep it straight, what happens, over the period, surgeon keep on pushing, and it can cause a hyperextension of the shoulder joint and dislocations. So I keep this IV catheter so that my anesthetist have to make her comfortable. So this is the long cannula I always like to put, and my height doesn't allow me to work without this flatter. So we keep this, and then the energy source, which will be the medial host, which will be the lateral, all should be sequenced so that you have a very good eye, hand, and foot coordination. So learn all these basic things before you start anything. Then comes is a uterine manipulator. Today, there are hundreds of uterine manipulator available in the market. But when I started, there were no manipulator. And this is still today, I use those manipulator. Now, what is this? Can you see that curvature? Now, this curvature has a serrations above. This doesn't allow the uterus to easily perforate. And these are my rings. Now, these rings are opaque ring if you see very carefully. So when my manipulator, naturally this curve we take out and put straight manipulator. And when this manipulator, goes in, there is no leakage of the gas because these are the solid. Why do we have so many varieties? Because it has to accommodate the specific size of the cervix. Too small a ring may not be able to delineate very well, and too big a ring, you may go little more laterally, more to the uterus. This is the thumb, where we keep the thumb so that I know how it is anteverted. I am believer of fifth hand in a vagina, and I'm going to show you how the fifth hand in vagina helps you to do apparent lengthening of the ligaments. So let's start with this abdominal entry. Before I go, I'll show you about that. Now, abdominal entry and trocar placement. Now, if anyone can do 10 weeks uterus, they can do 14, they can do 26, and they can do 36 weeks uterus. Because hysterectomy, basic principle remains the same. 3 pedicles on left side and 3 pedicles on right side and the cornu. Only thing is your port start going upper and upper if you are here. So when you have a large uterus, your port goes, your tip of the camera should have a panoramic vision. So at least 4 inches above as far as possible so that you can have a good inspection. So all the ports goes high. 30-degree camera, fantastic if you have it 30-degree. But since I'm using 3D telescope, I don't like 30-degree with it. You ensure good anesthetist, good assistant. What I mean by good anesthetist is who gives you head-low position and allows you to work. And your own level of confidence and probably the difficult cases in the early part of a day. Now, once you go in, don't directly jump for the surgery. First is confirm your preoperative finding. Multiple fibroid associated endometriosis is going to be there. Find where the ureters are. Now, these are the ureters where laterally. Now, whether I go in all the cases from the lateral pelvic wall, it all depends upon how is the lateral pelvic wall. So reconfirmation of the finding is very important. Usually I put ipsilateral 2 ports and then on a right side. Now, whenever you start the hysterectomy, as I said, is very simple. What is important is adhesiolysis and making the anatomy normal. So you will find that sometimes if there are many loops, all of us are having these patients of multiple fibroids with adenomyosis, endometriosis coming now, whom we gave a IVF babies. They are coming now for the hysterectomy. After the baby, they disappear. They don't do any follow-up, and then they come with severe dysmenorrhea and menorrhagia. When you know there are so many loops of bowel, one under the another, I probably won't use any energy source, but then the smaller nicks, and I will try and make anatomy normal. Now, sometimes your adhesions are so much that your portal entry is also not possible. This is a median obliterated ligament. The previous two cesarean fibroids, adenomyosis, previous laparotomy. Now, bladder will never come lateral to this. Bladder will always be medial to it, so you remain bindas here. Second thing is, again, only a grasper and a Caesar can also do a very good job, otherwise the harmonic. What is important is small nicks, fiber by fiber dissection. And you will realize that your curvature of the Caesar has to be beautiful. It should be direction of the Caesar is important, but this is how it was taught to all of us during residency, and that's how you perform. You just mimic what you have learned open surgery. So when you are doing with the Caesar, you see, I'm just opening up and I'm opening the spaces. Now, bowel, we all do very good bowel preparation. Can you see that? Dr. Amla Devi is talking. Can she mute herself? Okay, so can you see now the adhesions, the way you start it, you realize it automatically opens and get it. With the fear, don't go too much on the peritoneum. You will go into the pre-peritoneal subspaces. Now, once you finish there, your assistant hand can come. Now, it's complete frozen pelvis. I think Dr. Sanjay Patel has taught the entire country about simplifying laparoscopic surgeries. What is important is go from the identifiable tissue to non-identifiable. So the most important thing is go from the lateral paracolic gutters. And you should be by-handed surgeon. Remember this. Sometimes your graspers and Caesar, they both should replace each other. The Caesar can also do the retraction. You can see that all the folds are opening up, and I'm just cutting. I'm separating. Now, I will not go to the lateral pelvic wall immediately because I got to see a beautiful plane here. I'm retracting with the Caesar and I'm opening my planes with the grasper. Then now when I go down, I can see the part of the uterus. Very small fiber by fiber dissection. Small bowels are easy to be nicked. So you see, you do more on a serosa. I was told that this patient has nearly 60 cc of a fluid collection in the left posterior half. I'm happy. When there is a fluid collection, this will be always probably from the uterus into bowel. That is the space they will go into. So just see how what I'm doing. I'm just giving a small nicks and trying to open up. And that fluid collection space has come. You should feel happy because that's how I'm opening the posterior wall. Now I'm opening up completely. If you are remaining in this capillary oozing bleeding, it will stop on its own also. Or then you can use. Now, previous to cesarean, I will always go to the uterine at its origin, even if it is a medium-sized uterus, because sometimes the bladder may be so badly adherent. And in case if you try to go for the anterior window, what can happen is with the anterior window, if the bladder, the uterine vein or the uterine artery open up, you are in a trouble because you can't use a cautery there. The adhesions you have not done. So I never go without I separate out these Caesars with Caesar. The bladder has gone and now I'm taking out the right-sided adhesiolysis. So don't jump for a hysterectomy. Make the uterus completely naked of its adhesion and then keep on doing it. I'm just fast forwarding a little bit. and severely obstructed pouch of Douglas. Entering the peritoneum sooner can be considered than lateral. Can you see here? It doesn't look so bad, but when you go down here, you will find that the central space is completely obliterated. The pouch of Douglas is completely obliterated, while lateral pelvic walls are very clean. I'll just go and take the uterines here. You can go lateral to the infundibulopelvic ligament or a median to the infundibulopelvic ligament, and you can start doing it. Now, when you are doing the hysterectomy, now adhesiolysis is done. I usually have a habit of using a bipolar. Bipolar is my favorite instrument. And I say, you stop before the bubble stop. You don't have to keep on cauterizing, especially you have an advanced machine like RB or LigaSure, where the beep happens. Beep happens very late. Don't allow the charring. You see, I'm just stopping before the bubble stop so that this one doesn't. Usually I prefer to do the bipolar endocoagulation before I cut with the harmonic so that it becomes little bloodless fluid. Now, when you use a harmonic, what is the advantage of harmonic is it automatically opens up your spaces. Very important. I'm going to show you in the next video how it nicely opens up the spaces. Can you see that? Now, all the cases, I use the uterine manipulator and I'm just opening up and opening up. Now, this is a very virgin cavity. It means she had a normal vaginal delivery. Now here, if my laparoscopic camera holding person is showing me what I want to see, the anterior pouch, unless after the cornu, I open up the anterior lip of broad ligament, then the posterior lip of broad ligament, I dissect the bladder, and then only I reach to the uterine so that in case if uterine opens up, bleed also, my ureters are away, the bladder is away. Now the cameraman is showing me what I'm supposed to see. Upper uterus is 10 weeks, 20 weeks, or 30 weeks, makes no difference. Nowadays, I see everyone is jumping for the uterine at its origin. Do I advise in all the cases? No. Now you see, she has a large vessels. It's very virgin. I have kept the manipulator. Uterus is completely on opposite side. Can you see how much? This is a cakewalk case. I have so much of an apparent lengthening of the uterine. The ureter and the uterine, 2 centimeter, no. This is a uterine. This is the lateral pelvic wall. Here, if I go for the uterine at its origin, I will be more closer than doing directly uterine here. So I'm not going to complicate the simple cases. Only thing is open up your spaces in case if that uterine bleeds. I'll show you here how it comes in. Completely moved out. When you are opened up the anterior and posterior lip of broad ligament, the current doesn't transmit laterally. And I'm just cutting it and you are seeing now if the vessel opens, don't hold the vessel tip. You will have a charring, you will have a sticking of the instrument. And that is why you should always make uterine naked before you start cutting the uterines. Now, it is always helpful to skeletonize your vessels. That helps you to know the course of a vessel and better obliteration of the lumen and hence sealing. Take the uterine as high as at the internal os level and then dissect medial to the uterine to avoid any ureteric. That's how it was taught to me in open surgery, that once you take a uterine, you should always go medial to the uterine. But sometimes, this is an unedited video. Sometimes I have to go for the uterine, as I showed you in my previous case also. It's very simple. Usually my approach is from round ligament to the infundibulopelvic ligament. Keep on going straight. Iliac vessels, the ureter, longitudinal structure. So move your hand longitudinally, craniocaudal. The first thing you will see on the medial side is the ureter. Laterally are the iliac vessels. Go deeper in the loose areolar tissue. The first organ or the first structure, the tube which crosses is uterine. But directly don't jump for the ligation or a cautery of the uterine, depending upon what the case is. Always see its origin and always confirm its crossing on the ureter. Only when you confirm its origin and only when you confirm its crossing, you know that it is uterine. There can be sometimes anomalies and you don't want to just cauterize anything comes in. Now, if you are keeping the ovaries, I will always go cauterize here, but don't go very close to the uterus. And when you are removing the ovaries, always remember, see, this is an infundibulopelvic ligament, multiple fibroid. This is the lateral most. Ureters are down, and that is lateral most. Then I'll go second medial most where I have to cut, and then the medial most where I have to take it. Now, when I have to go, always remember, with the multiple fibroid, you will have a large vasculatures in the mesosalpinx. They can retract very easily. So don't hug the ovary here or don't hug the uterus here. Remain in the center so that you will not have a bleeding happening from the uterines. Now, this is the uterine. I can see it so well. So I'm just going to cut this. I'm cauterizing and I'm cutting. Just lift it up and then you cut that. Now, once you cut it, this is the complete vasculature. As I told you, you should make this uterine naked. So keep on taking out all the loose areolar tissue. Don't jump for a cautery with those loose areolar tissue, because what is going to happen is you may cause only superficial cautery. The deeper cautery will not happen. Now here, if my hand is too high and not reaching, I can come perpendicular to the vasculature. I can come from the right side and take this complete vasculature. Can you see? So another important tip is your instrument should be always right angle to the pedicle. So energy source which is coming right angle to the pedicle, you can seal it in little better way. And then you can cut and just go down. Mobilization of the bladder, very important, and then the opening of the ward. Now here you see my uterus is getting moved right and left and above is by my manipulator. Can you see that? It's nicely moves. The uterus is up to 24 week size. The person is pushing the uterus so that I go away from the bladder. Always have a habit of checking the pouch of a Douglas. Sometimes we do the good bowel preparation and the colon and the this one may be very much adherent to this. Now the vaginal ring has come there. Even today, I love, there is always a discussion when we do the cases in a workshop, whether to use a harmonic or the monopolar. Now the ring which is coming in is resistant to monopolar. So it doesn't get, if I use a harmonic, it just gets cuts on those. And I'm not going to go. I'm using this manipulator for years together. So what is important is push the ring and then cut. Now here only the bladder, I see to it that at least 2 centimeter bladder is down. Can you see that? If I do this, bladder has to be at least 2 centimeter down so that I get a good vault. I'm going back here and showing you. So when the ring comes in, can you see? When the ring comes in, this is a bladder. I will dissect all this fascia will go down. Why 2 centimeter? So that you can do the vault closure with it. Reconstruction of the vault is very important. Sometimes very large uterus, you sit vaginally for morcellation, but please don't do the vault closure vaginally when you have opened the laparoscopically. So this is a uterosacral ligament. S2, S3, S4, it goes. So don't go at the tip. Here I'm checking, can you see more than 1 centimeter? Usually your laparoscope has a magnification. So don't take much at the edges. Then I go and tie beyond the angle medial to that uterine vessel. So beyond the angle, but median to the vessel is very important. So your angular vessels you obliterated. Then I go on the left side. I give a tremendous importance to the vaginal angle. I know my friends who have done relaparoscopy because the vaginal age, the angle started bleeding after the surgery when the CO2 pressure is off. And they have to re-go inside. So what I like to do is, one, you must have seen, I don't cauterize. Cauterization will cause necrosis, weakening. Don't cauterize. The patient will keep on coming with the white discharge or a secondary infection and bleeding. In open surgery, I don't remember I have ever cauterized the wall. The same principle, uterine laterally, I'll go beyond and automatically these capillaries and the veins will stop on its own. Please don't cauterize. So I have secured the angle very well. And then I will go from one angle, take as much fascia as you can so that you have a good pelvic fascia back. So pubocervical fascia, vaginal fascia, and uterosacral and the angle. Now, sometimes if you find the pouch of Douglas deep enough and on a speculum examination, you found that the posterior vaginal wall, we all know the wall prolapse happens is nothing but the enterocele. That is the apex of the wall prolapse. So you can just do the plication of the uterosacral or you can do the Muscovite stitch. The choice is yours, depending upon how the thing is. It takes you another 2 minutes to go. Just be very careful that the ureters are much laterally and you pull up the wall more so that you will avoid. So you not only have to see the immediate complication, you also have to see the long-term complication. The long-term, either the wall prolapse, that is a herniation from the wall, or the umbilical hernia. Both the complication of long-term, you should know how to prevent them. So for umbilicus, I will always go by Z technique. My incision on the entry point of the rectus and the peritoneum is never one below the other. If I have to take out the fallopian tubes, I will always take out after the hysterectomy because I don't like it. These patients, we don't keep any catheter. We give a thorough lavage. Patient walks to the toilet within 2 hours of shifting into the room. It's a mandatory. It helps. It's not only the coming back, the bowel function, but it's very important that patient is walking so that you avoid even in obese patient, the thromboembolism complication. Now, do I do only always without the uterine screw? No. Sometimes you have the cauliflower-like fibroids, so many fibroids. The uterine cavity is small. Unless you have these myoma screw, it's not possible to go and see the further pedicle. But you see there is a bleeding. Up till now, you have seen the bloodless surgery. Because anytime you put the myoma screw before the uterine, you are going to get the retrograde bleeding coming from the uterus. So, but it's okay. Sometimes you might have to use the rest of the principle remains the same. How big is the big? It's in your definition. As you move on, your inclusion criteria increases and your exclusion criteria goes on decreasing and you start accommodating more complicated cases. So this patient has up to zipisternum. I myself is at zipisternum, so you can't see the upper. Go determined. Never be overconfident. Always take a consent of laparotomy also. Once you go analyze, patient don't have an associated endometriosis, you are happy. Initially, you feel there is no space. Start doing from one pedicle. Follow the same principle. If you are using a harmonic, this simple blade and not the SA, where it can coagulate 7 mm vessel, I will always like to do in such cases bipolar endocoagulation. And you start doing, automatically you realize your pedicles open up. Now here also my myoma screw is here. It may not help me at the cornu, but it will help me when I reach down to the McEnrods or the uterine. Can you see that? I have an apparent lengthening of the uterine and I'm going and taking it out. And that's because the manipulator helping me there. More than 2 hands cannot come there. Just open up your spaces very well and then coagulate and do, because you don't want the bloody field. Otherwise, you can finish up like anything. Now, the cameraman is trying to show me what I want. Of course, they have an obstruction of all those multiple fibroids before they show me. But now, upper uterus is 12 weeks or 36 weeks. Makes no difference. You can see how the manipulator is helping me to make the uterine or the lower pedicles more apparent lengthening of them. And you can just proceed slowly and steadily. Bipolar system, monopolar system, and the harmonic probably will help you. Vaginal ring coming in, your manipulator in, is going to help you than opening the vault without the ring. I know there are great endoscopic surgeons who don't put the ring. I feel ring helps me to elevate the uterines. It helps me to push the ureter further laterally. And then I'm just doing the closure. More difficulty in these cases are how to remove, whether you will do morcellation, laparoscopic, whether laparoscopic part or uterine, all is your choice. Can you see that? It becomes a bloodless surgery if you go determined. More difficult, just let me know when my time is over. More difficult. This is probably the last video though. Cervical fibroid, broad ligament fibroid, lateral uterine wall fibroid. They don't give a upper too much of a bulge. They are horizontally placed. They are more difficult than doing the vertical all fibroids because you don't have much lateral space. But what is important is go all determined upper port and you will go and do it. I'm just skipping these few more tips. So friends, we are what we repeatedly do. Excellence is not then act, but becomes a habit. Always think that after climbing, there are many more hills to climb. You are never. We all started with single chip Lemke camera. Then we went for the 3-chip camera. Then we got a HD system. Then we got a 3D system. Then we got a robotic system. What is important is whatever the system, it makes your surgery simplified. Today, I definitely feel when I'm doing a 3D, I don't know how I was doing with the Lemke single chip, the level 4 endometriotic frozen pelvis surgery, because I feel it's impossible for anyone. And I really adore the young gynecologists who work in 2D so beautifully. I adore them. So prepare yourself well before each surgery and determine to excel yourself every day. You can't say, oh, more than 2.5, 3 decades I've done. Once in a while it happens, but for that patient, it's 100%. So see to it that you come out very well. When was the last time you did something for the first time? You should keep on asking. Endoscopy has made us innovative, creative, and it's very important that every day you change. The way you used to do the hysterectomy 10 years ago, 5 years ago, 2 years ago, and today, it has to be changed because there is an evolution in your thinking, knowledge, and the machineries. Robotic, yes, I do robotic. But let me tell you, I don't do for hysterectomies and myomectomies. I do mainly for the pelvic floor and the tubotubal microsurgery. It's a great to be having a robotic in your OT, but not necessarily Dr. Rajesh to get bored just standing there when I'm doing a robotic surgery. It's the experience which makes the clinician expert. Thank you, friends. Everyone, if I can do, everyone in this country or on this earth will do. Nothing is impossible. Thank you.
Thank you so much, madam. It was truly wonderful. My pranayams to you, madam. I remember the last time when you came to Trichy, we gave a standing ovation. You were truly inspiring, like all of us took lots of points from you. And today's talk was simply superb. Like you said, just 7 steps away. It's very simple. And if I can do it, you can do it. And all those things were really, really inspiring for the youngsters to do more and more. And basically, what is your take-home message was preparedness. Like mentally, you have to prepare for the next day, what you're going to do, what you thought in your previous talk, like map your anatomy, map the myomas, so that you really know what you're going to do. Check your equipments and all these things really, really, this reinforcement we're definitely going to help us in doing a better job. And it was a wonderful, wonderful talk as usual. You deserve the best and wish you all the best for all your endeavors, madam. Thank you, madam.
Lakshmi, you won't imagine. Today morning, I remembered you, Jayam, Ramni. I said, Trichy के friends को कितने महीने में बात नहीं की है. And
We're so happy, madam.
Flyer in detail. And when I came to know you are chairing, I was so happy that I'll be meeting you. That's a
Also-
testimony.
Me too, madam. Very excited to meet you as well.
Thank you. Thank you, dear.
Thank you, madam, for the inspiring talk. And wish you all the best, madam.
Thank you,
in
Shanti.
your
madam.
upcoming elections.
Thank you so much, madam, being there. Thank you. All the best.
Thank you, madam. It has a wonderful talk. So moving on to the next session, I'd like to invite Dr. Umayal, madam. Very proud to introduce her here. She's also my mother. And I know madam is currently the consultant of Shilpavan Hospital, Tambaram, and she is currently the founding secretary of Kanjipuram Moji Society from 2019. And madam is also the treasurer, president of IMA Tambaram currently. I like to I welcome Umayal madam to introduce the chairperson for the next topic.
Very good afternoon. I would like to introduce Amala madam for the chair of the next topic, tips and tricks in hysteroscopy. Madam is the founder, secretary of Dindikal Option Gynec Society, and presently she is the president of the same. And she is the East member of TNFOG, and she is also the managing director of Annai Perinbam Hospital, Dindikal, and she is the retired JD admin and project officer of in Chennai. And welcome you, madam, to chair the next session. And I would also like to welcome Dr. Malati Prasad, the other chairperson. She is the president of Trichy OB-GYN Society. She is the director of Trichy Fetal Medicine and Fertility Center. And she's also a consultant in maternal and fetal medicine in TFMC Hospital, Trichy. And she has got many awards. She has got the first prize for the paper on fetoscopic skin biopsy and epidermolysis in the conference Dakshin 2011. And I welcome you, madam, to introduce the speaker, Dr. Sneha Buer, madam.
Hello, Malti madam. Hello, lovely to see you.
How are you? How are you? I was just thinking that you did such a splendid job when you came to Trichy. We're all very mesmerized by your talk and inspired, I would say. How are you?
Lovely to see you, Malti madam. Lovely to see you.
All the best for your early endeavors.
Thank you, ma'am. Thank you. Lovely. I feel like, I belong to Tamil Nadu.
Oh, great.
So much love I get from Tamil Nadu.
Yes. So can we go to the session, please? Thank you. Bye, ma'am. Thank you, Dr. Umayal. I think I have great pleasure in introducing the first speaker, Dr. Sneha, who is going to talk to us on tips and tricks on hysteroscopy. Can we have her CV, please? Can we have Dr. Sneha's CV? Yeah, I'm just touching the salient points. She was the chairperson, press committee to 2019-2021, governing council, ISOG 2021-22. She's an executive committee member of AMOGS, and she's a lot of research papers, and she has been the organizing chairperson for many conferences. She has a lot of talks and publications to her credit. So we all know that hysteroscopy is like right hand to all of us apart from the ultrasound. So we have Dr. Sneha who is going to talk about many tips and tricks on how to combine both together to give the best to the patient. Over to Dr. Sneha, please.
Yeah, thank you so much, Chairperson, for the kind and generous introduction, I would say. First of all, a very good evening to all of you. Once again, I acknowledge the presence of Dr. Malati and of course, Dr. Shanti Rani, our dear friend, Dr. Charmila, who has just joined, and so many other, delegates and dignitaries here. With this, I would just like to share my screen, and please let me know whether you can see my screen.
Yes, ma'am.
Yes. So my topic is very simple, the tips and tricks of hysteroscopy. Let me start by saying that all of you know me as breast committee chairperson. So my field of interest was breastfeeding, benign breast diseases, and making awareness and screening and early detection of breast cancer. As medical disorders committee chairperson, I have been working very hard on the medical disorders, and as hardcore obstetrician, I'm a journalist actually. The obstetrics and gynecology, endoscopy, infertility, everything I'm practicing. Endoscopy, I'm practicing only basics, and so I would like to go ahead with the basics of hysteroscopy. So I would just start with what is hysteroscopy. Hystros means uterus, and scopy is to look into the inspection of the uterine cavity by endoscopy with access through the cervix. It allows the diagnosis of the intrauterine pathology and serves as a method for surgical intervention as well. We can have, the changing trends and of course the history of hysteroscopy. We just talk about what is currently used as the most popular office hysteroscopy. This is a minimally invasive procedure that has been shown to be highly accurate in the diagnosis of abnormalities of endometrial as well as endocervical canal. So it allows the direct visualization of the uterine pathology without the need of general anesthesia and the use of operating room, generating cost savings and of course the greater compliance amongst the patient. So just going along the timeline, hysteroscopy was once upon a time like a Cinderella. It was just a dream for the gynecologist, but over the period when dilatation and curettage was the only method of treating the abnormal uterine bleeding, when we used to call it as dysfunctional uterine bleeding, and of course for diagnosis. So we used to say that dilatation and curettage is not only diagnostic but therapeutic as well, but it was associated with its own disadvantages, the need for anesthesia, need for hospitalization, also the risk of complications like perforation, adhesions, poor diagnostic accuracy. Then came the changing trend and the traditional technique of hysteroscopy in 1970s to 80s, and then it became the ambulatory procedure in 1990s. Of course, nowadays we have the office hysteroscopy. Numerous studies have indicated that office hysteroscopy has definite advantages in comparison with the blind technique of D&C. So let us talk about the traditional hysteroscopy, where this was the picture initially, where the speculum was put and a forceps was used to catch hold of the cervix, and the scope was passed through the cervix. Definitely, considering the rigid scope and the larger diameter, it was lots and lots of dilatation was needed. So, owing to the large diameter of the hysteroscope, preparatory cervical dilatation was mandatory. So naturally, at least the local anesthesia was necessary. And of course, if at all for this, the hospitalization was required. And now we are coming to the modern technology of office hysteroscopy. In early 1990s, advances in technology and techniques made hysteroscopy less painful and invasive. The method helped to reduce the number of procedures performed in the operating room itself. At the same time, the number of ambulatory procedures like the office hysteroscopy was seen to rise. Of course, it has the intent of benefit of omitting the need for anesthesia as well as the dilatation. So the pain during the procedure and the discomfort after the procedure was less. Now, why office hysteroscopy is in trend now? Because of the advent of the smaller diameter of the hysteroscope, the use of saline solution which has replaced the CO2 as a distension media. Also, the vaginoscopic technique has widely contributed to the diffusion of this technique worldwide, and currently it can be considered as the gold standard for the examination of uterine cavity. I'm sure all of you know this. This is what you need for the office hysteroscopy. The endoscope, which has got a rigid scope, and the external sheath, which has got the channels for the operative instrument and the suction. And of course, all of these featured on a instrument trolley. Then, of course, came the flexible hysteroscope. So what are the advantages and disadvantages of each one of this, and how do you select which one is better? So coming to the rigid hysteroscope, these rigid ones, they are composed of two parts, the scope per se and the outer sheet, which has got a total diameter of 2.9 to 4 millimeter. The outer sheet comes with the suction irrigation valves to control the inflow and outflow of the distension medium as well. Operating channel is present from which specially designed instruments can go through for operative purposes and also for the retrieval of the endometrial tissue for biopsy. What are the pros of this rigid hysteroscope? They are the same as non-office hysteroscopes. If the clinician is trained for those routine hysteroscopy, no additional training is required, and of course it can be used without inserting the vaginal speculum with a non-touch or the vaginoscopic approach. It can be used with suction device, while a great variety of instruments are specially designed for this, and the scopes are available in 12, 25, 30 degrees angular vision. So the problem with this is they come in many parts. Also, the optics are very, very thin, maybe from 2 millimeter in diameter. So they're fragile and they're difficult to clean as well as disinfect. They have a greater width compared with the flexible hysteroscope. Now coming to the flexible hysteroscope, why they have to be preferred? They're compact. In fact, everything comes as one part only. Even the light source is permanently fixed on this. It does not come with an outer sheet. The flexible instruments can be inserted via working channel for the biopsy in a minor surgical procedure. The visual angle of up to 120 degrees due to flexibility, and there is no external manipulation required, hence it can in fact minimize the discomfort to the patient. Cleaning, disinfection and storage are simpler as compared to the rigid hysteroscope. The possible chances for perforation are away from remote, I would say. The vaginoscopic approach is not possible here. Also, the patient experiences less pain and discomfort. So what is the basic setup of obstetric the office hysteroscopy? The basic setup in order to perform, of course, you need a scope and a telescope, a camera control unit connected to a DVD recording device, a light source, a monitor connected exactly the same way as the operating theater, and all of them placed on a equipment cart. An irrigation suction unit for the distension medium, and additional equipment should be ready. They can be the syringe, which is required, also the cervical dilator, vaginal speculum, sterile gauze and forceps, all of them placed in a secondary equipment cart. So lithotomy position, very important. All of you know this. The anesthesia, I think if at all you need the dilatation, maybe you need either a cervical or a paracervical block, maybe in some cases a short general anesthesia. Conscious sedation is not used here, it does not contribute to the pain relief. Local anesthesia is much better, and also dangerous complication can occur. It cannot be, if at all it happens, cannot be tackled if the patient is not under anesthesia. So definitely the choice of anesthesia should be depending upon the anesthetist and the operator as well. Maybe an hour prior, you can give the injectable or NSAIDs. Use of opioids is not recommended. Choice for analgesia prior to or during the procedure should be decided by the clinician, as of course you have to select as per the patient's history, the possible vasovagal reactions, and of course other factors you have to consider. The distension medium used in office hysteroscopy, it is the normal saline or CO2. Choice of medium is at the discretion of the clinician. The advantages of normal saline use over CO2 as a distension medium are, it provides a better visibility, and also the clearing out of blood clots and debris is better. Less possible vasovagal reactions are there. The setup is more simple and more practical as compared to the CO2. What are the types of office hysteroscopy? As we have already said, the diagnostic and the operative office hysteroscopy, the most accurate diagnostic tool for endometrial pathologies. This is basically office hysteroscopy. We would say that it is mainly of diagnostic use, though minor surgical procedures can be performed. A second line tool for primary diagnosis deriving from when you do a 2D or 3D transvaginal ultrasound, it can be used as a second line tool for diagnosis. Avoidance of the taking general anesthesia, reducing time of the whole procedure, reduces the cost by 40 to 60% because it doesn't require anesthesia and hospitalization. So definitely it gives you office-based environment, and of course the patient is ready to work immediately after the procedure. Office hysteroscopy as operative has definitely got limitations. Only minor procedures can be done, like endometrial biopsy, removal of small polyps or very thin septum, maybe products of conception. What are the contraindications? That is very important that we have to keep it in mind, that we rule out the contraindication, that when the patient has either vaginitis, pelvic inflammatory disease, or active bleeding from the genital tract. Of course, malignancy is not a contraindication for office operative hysteroscopy. You can take a biopsy and confirm the diagnosis. In premenopausal women, abnormal uterine bleeding, also other indications, the fertility investigations. Office hysteroscopy is very useful in the investigation of endometrial cavity in women who have undergone the few cycles of IVF and two failed implantations. At the same time, the patient who has suffered recurrent miscarriages can be investigated with office hysteroscopy. Small endometrial polyps, all these things can be diagnosed and get tackled with office hysteroscopy. The women have to, women of CA breast who are on tamoxifen, and they either suffer from abnormal uterine bleeding or they need a follow-up when they develop endometrial hyperplasia. This is a good procedure to go ahead with office hysteroscopy for operative purpose. In the postmenopausal woman, any woman who suffers of postmenopausal bleeding, unless proved otherwise, has to consider as malignancy, and definitely office hysteroscopy is a good gadget, I would say, to tackle the situation. In cases of cancer, the benefit of accurate diagnosis outweighs the risk of spreading neoplastic cells into the abdominal cavity, and thus dilatation and curettage is advised not to be preferred over the hysteroscopy. Now, what are the potential uses of hysteroscopy and what precautions we have to take during the hysteroscopy? That I'll just make it short. The conditions, abnormal uterine bleeding, what we have said, diagnostic hysteroscopy and targeted biopsy. Endometrial polyp, we can tackle as polypectomy. Infertility, Asherman syndrome, the lysis of the adhesions, retained intrauterine device, we can remove the retained products of conception, and of course the uterine septum you can tackle here. So what are the tips, I would say, as if you want to use this office hysteroscopy and what to avoid complications? So office hysteroscopy should be conducted, of course, away from the formal operative theater, but the room has to be appropriately sized, well equipped, and well staffed. With the adjoining private changing facilities and a toilet. The nurse should set up the room where the procedure takes place in order to ensure that all the necessary equipment and instruments are in proper working conditions and readily available. And if the doctor or the nurse is able to develop a plan of care that will help to minimize the patient's anxiety, a more positive outcome and increased patient satisfaction can be expected. During the procedure, the nurse or the resident should provide emotional support to the patient in order to further reduce the patient's anxiety. About the rigid and flexible hysteroscope, I would say the miniaturized rigid hysteroscope. The miniaturization of this instrument effectively reduces the difficulties both for the operator as well as the patient. It allows even less skilled gynecologists to perform office hysteroscopy. So flexible hysteroscopes are very advantageous, but even the miniature rigid hysteroscopes are definitely helpful to the less skilled gynecologists. Smaller hysteroscope size makes its introduction easier and less painful compared with the conventional one. So we should prefer the miniaturized rigid hysteroscope. The oval profile rigid hysteroscope, of course, the uterine flexion angle makes the internal uterine ostium, which is usually circular or oval, with a transverse main axis and a diameter of 4 to 5 millimeter. With a simple rotation of the scope on the endo camera by 90 degree, the operator can adequately, align the longitudinal main axis and the transverse axis. It allows more easy and less painful, the entrance of the hysteroscope into the uterine cavity. If at all there is a cervical stenosis, then you can use a wide set of 5F mechanical instruments to overcome the stenosis. If at all you have a moderate stenosis, you can use semi-rigid 5F mechanical instruments. And of course, you have to insert the instrument and try and break it without causing much pain and bleeding. So once the fibrous tissue has been identified, the fibrous ring may be cut at 2 to 3 places, and alternatively, it may be stretched by grasping forceps inserted within it. So just once you overcome the cervical stenosis, you can easily visualize the internal aspect. The main advantage of this technique is prompt identification of the false passage, sudden increase in the patient pain, the fresh gush of bleeding, visualization of red tissue. That is how you can actually make out it. The main disadvantage of this technique has been recognized in the fragility of the instruments used, which are prone to break. Of course, the bipolar electrodes are significantly being used for more in the cases of stenosis. It may be in combination with the IUO. So severe stenosis may be resolved by creating 3 or more radical incisions. So what are the advantages of office hysteroscopy for the patient? For the patient, it is mainly I would say it is mainly designed for the patient because it has got so many advantages. It is done as an outpatient procedure, doesn't require the hospital environment, the operation theater as such. Anesthesia is not required. Maybe the pain is not much, and the post-operative recovery or hospitalization is not required. Of course, the patient may get little cramps post-operatively. For the clinician, it gives you additional facilities, in addition to the accurate diagnosis, the operative options is provided. A future management plan can be easily scheduled after the end of the procedure, and further pathology report from the biopsies is expected. Miniature hysteroscopes with a low width inflow channel for the distension medium provides low pressure distension of the uterine cavity, and cases of soft tissue structures like polyps, adenomas, and adhesions also can be broken. In the private gynecological practice, the application of office hysteroscopy extends the list of provisional services and gives the clinician added value. So the points to be remembered here is office hysteroscopy is a very useful technique for the diagnosis as well as treatment of the intrauterine pathology. So in an office-based environment, the primary use of office hysteroscopy for diagnosis of various conditions which we have talked about. Also, the equipment selection should be based on the types of the procedure you have planned in the office setting. Appropriate patient selection is the most important component for both patient as well as the clinician, and care should be taken to attempt to reduce pain and anxiety during office hysteroscopy with recommended methods, including the pre-procedure analgesics or vaginoscopy approach and appropriate counseling. So with this, I end my talk, and once again, I humbly request all of you to support my candidature and nominate me from all the societies of Tamil Nadu. Thank you so much. I seek your blessings and wholehearted support. Thank you, Tamil Nadu Societies, for the opportunity. Thank you, chairpersons, for the wonderful listening. And I would like to answer whatever queries, if at all. Thank you so much. Over to you, Dr. Anit.
Thank you so much, madam, for a wonderful talk. It was very crisp and you covered from basics to advanced in a very coherent way. So
thank you so much.
The chairpersons, do you have any comments? Okay, so I invite Dr. Umial ma'am to invite the moderators and the expert panelists and panelists for next. So,
evening. Our next academic session is on difficult scenarios in laparoscopy. I would like to invite our chairs, our coordinators for this program, Dr. G. Jayamala and Dr. Sumati Sendilkumar from Salem. Dr. Jayamala is the president of OG Society of
Is there some network issue?
Can you hear me?
Yes, ma'am. Yes, madam, you are audible.
Kekda?
Yes, madam, audible.
Okay. Dr. Jayamala from Salem is a consultant obstetrician and gynecologist, and she is the president of OG Society of Salem and assisting managing director, Rainbow Hospital for Women and Children. She was the co-chairperson for the UFOXY South Zone 2022 at Salem. And Dr. Sumati Sendilkumar, who is the co-moderator, is the director and senior consultant and gynec endoscopic surgeon, SS Medical Center, Salem. And her special interests are high-risk pregnancies, gynec endoscopic surgeries, and infertility. And our dear Charmila, a close friend, is the expert here for the difficult scenarios in laparoscopy. And she is currently the vice president-elect of FOXY 2024. She's the chairperson of the Clinical Research Summer Committee 2016 to 18. She is the ICOG Governing Council member 21-23. National coordinator of UNICEF MEDA FOXY PG program and ISAR Gurukul. And she was also the joint secretary of Dystosis India Association. And the panelists are Dr. Kirtika Devi. She's from Kanchipuram Ops and Gynec Society, and she's the medical director of Babu's Maternity Hospital. Her field of interests are high risks and infertility. She's practicing for more than 25 years. Dr. Shobana Priya is again a gynecologist from Kanchipuram OG and OG Society. She's a senior assistant professor of Chengalpattu Medical College. She's also the joint secretary of IMA Tamram, and she has received various awards from the Chengalpattu Medical College and also from the collector. She's a very academic-oriented person. And Dr. Sri Sudha, welcome. She is a laparoscopic surgeon and the medical director of Anna Teresa Hospital. And she is also a very, very busy practitioner here. And Gayatri from TENI. She's the founder secretary of TENI. And she remained the secretary till 2022, has conducted various workshops, and she's spoken in various state and national forums, a member of IAGE and IFS, and she's a very good friend of mine too. Welcome, dear Vanita. Next is the Dr. Vanita Rukmani from TENI, Obstetrics and Gynec Society. And she is a consultant in obstetrician and gynecology from Nattati Nadar Hospital, TENI. And she has been also a very active speaker in various state and national conferences, and she has published plenty of papers. And I also invite Dr. Selvarani Jairani from Sri Arogyam Hospital, Dental. So the panelists are all there, and I request Dr. Jayamala and Dr. Sumati to take over. Jayamala?
Can I share? Yes, ma'am. Let me share. First of all, thank you, ma'am, Dr. Umayal ma'am and Dr. Sharmila ma'am, the entire team for giving us this opportunity. Yeah, and I welcome my panelists, Dr. Kritika Devi, Shobna Priya, Dr. Sri Sudha, Dr. Gayatri, Dr. Vanita Rukmani, and Dr. Selvarani. Yeah. First, I think in a short notice, we have prepared this and we have made it very short and sweet, very simple. Okay, as Dr. Sunita Tandulwakar ma'am had already, given a big lecture, and she had highlighted all the salient features. There's not much going to be a recap. Okay, as you know, the minimally invasive surgery continues to transform the field of gynecological surgery. New advances in technology are being employed rapidly, enabling us to perform more complicated surgeries. As we were always taught, see one, do one, teach one approach is not feasible in laparoscopy. It has a long learning curve. The surgeon has limited range of movement, poor depth perception, difficulty that in tactile sensation, and it's a non-intuitive motor skill that is difficult to learn. These are the things actually we were told. But advances in technique and devices like HT, 3D scopes, marshallators, energy sources, barbed sutures, and education by simulation training, and all these webinars, live workshops have shortened the learning curve. So I think every gynecologist is a laparoscopist now, and it should be a part of our training program from the beginning. So with that introduction, we'll start with our first case. My panelist. Yeah. So first case, the 45-year-old Mrs. AK with a BMI of 40 with previous 2 normal deliveries. His past medical history is nil relevant. She's complaining of severe menorrhagia and dysmenorrhea. She's anemic. Her ultrasound showed severe adenomyotic uterus, which is 12 week size, had Mirena inserted, and it fell out after 2 months. So she was posted for laparoscopic hysterectomy. So this is the case scenario. So Dr. Kritika Devi, what are all the preoperative preparation you'll be doing? Can you hear me?
Kritika has to unmute herself.
She's
muted. Kritika, unmute yourself.
Welcome, Dr. Sharmila ma'am.
Hi, Jayamala. Such a wonderful journal of yours. You should actually put it throughout Tamil Nadu also.
Oh, thank you so much, ma'am. Thank you. That's very inspiring.
Yeah, it's an e-journal and all the articles extremely good. I have to read through again, actually. It was so much.
Sure, ma'am. Thank you. Thank you for your time.
Kritika? Yeah, I think
yes,
she's now.
I would like to do a complete blood examination, complete blood count, urea, creatinine, liver function test, ECG, echocardiogram, chest X-ray, and now the current scenario, COVID test, and rule out anemia. And if she's severely anemic, I would like to transfuse the required units of packed cells and then take her up for the hysterectomy.
That's very good. And here I've highlighted her BMI is 40, right? So before taking her to theatre, would you like to get an assessment by any of your colleagues?
Before, also a thyroid function test, I forgot to mention, to rule out any hypothyroidism, and I would like the anesthetist to see her beforehand and give a fitness.
Yeah, excellent. So cardiac assessment also, because with this obesity, she might have some comorbid conditions as well. So it is better to get a cardiac opinion and an anesthetic assessment. Very good. Okay. Any bowel preparation?
Yes, ma'am. Bubble.
I would like to keep her on liquid diet 24 hours prior to the surgery, and give her lactulose 48 hours before the surgery, and give her some anti.
Yeah, actually, with this increased BMI, I think bowel preparation with the PEGLAC also might help. Okay, and any other preoperative preparation?
It can be reserved, madam.
Yeah,
She's
excellent. Yeah, as you said, yeah, cardiac anesthetic assessment, bowel preparation, and a prophylactic antibiotic.
To do some coagulation profile, especially in this patient, because the postoperative DVT is
Excellent. Yes, ma'am. Thank you.
time, and an activated partial thromboblast in time would be a better addition to have it beforehand, before posting her for a surgery.
Okay, what
Ma'am,
are your
actually, when we give enema, no, there is some the bubbles are very blotted, and we couldn't do surgeries. So we usually give patient only Dulcolex, ma'am. We don't give enema to the patient.
Yeah, you're right, ma'am. Enema, if you give, the rectum is empty, but the rest of the bowel gets bloated. So it is better to give PEGLAC than giving, enema.
Enema.
So I think to give PEGLAC.
So what is the actual time? What is the actual time to give Pectilac, ma'am, before entering into the surgery?
Yeah, what I do is the day before I ask her to have, especially in these obese patients, only liquid diet on that day. And, 6 o'clock, they can finish off whatever their liquid diet they're taking. After that, they have to take PEGLAC. It takes usually 1 to 2 hours to finish off the PEGLAC, and then they pass motion. So then
actually, with the Dulcolex also, the bubble preparation is very good.
If the 13 patient, Dulcolex will do. But obese patient, and then if you're anticipating difficult surgeries, it's better to give PEGLAC.
Yeah. Okay, ma'am. Thank you.
So, perioperative interventions, what will you do?
Yes, ma'am.
Interventions.
Perioperative interventions, what are the precautions you will take before start your surgery?
Proper positioning of the patient since she's obese.
Excellent, yeah.
Yeah, the BMI is 40, so for the obese patient, we need to follow the protocol and the positioning of the patient. And with a sandbag can be placed just below the hip so that we have a good good positioning, and head down after trocar placement. Since it is a 12-week uterus, trocar placement would be in general for a normal supraumbilical primary trocar and lateral trocar. There may not be of much difference in the trocar position, because it is an adenomyotic, will be of hardly 12-week size uterus. No? Yeah. Then for the bubble head down will be better, ma'am.
Yeah, we'll come to that later. During perioperative interventions, would you
difficult airway is always an concern we have to take care of it, ma'am.
Yeah, that I think our anesthetist will deal with that. Yeah. So, like, we would prefer to decompress her stomach, right?
Yes.
So we put in a right tube.
Actually, decompression is not needed for all cases, no, ma'am.
Not all cases, ma'am.
Yeah.
Because for BMI is 40.
Bowels are distended, we can insert the right tube, ma'am.
This is only this particular case scenario. It is only case-to-case basis. This is not a generalized one. This is only for this patient with a BMI of 40. I prefer to have her stomach decompressed. As Dr. Charmila ma'am already said, DVT prophylaxis, you can put her on dead stockings or intermittent pneumatic compression.
No, the main thing is keep all your instruments ready. You will not know suddenly there will be one need for an instrument, and that will be in the cupboard. So the surgeon has to be very careful that they see it because such a high BMI, and you will need one instrument or the other, and your nurse will not have it ready. So the anesthetist has to come and see the patient, make sure that he's very clear how he is going to give the anesthesia, that all the difficult airway has to be seen the previous day itself. And the surgeon has to be very clear about the instruments as far as laparoscopy is concerned. In open surgery, you can always get away with changing your instruments and doing something or the other. But in laparoscopy, the particular instrument will make such a big difference to your surgery. And the other thing is, you position the patient before you go and wash up, because you allow somebody else to position. It will never be comfortable for you. So I always make a point of positioning my patient before I go for laparoscopic surgery, particularly because the assistant sometimes may not do it well, and that will take more time under anesthesia. These precautions you should always take during surgery.
And we have to be ready with the instruments for open hysterectomy also in case of any difficulties.
Yes. And so it's always better to prepare as a team when you are posting a difficult case the day before itself, even with your ward boy, your assistants, your anesthetist. If you need your colleague, it's always better to plan it properly the day before. You can have a meeting and then you can discuss, or you tell your staff what you need beforehand. So entry points in such case. So what would you prefer?
If entry point is supraumbilical, ma'am, if she has done a sterilization before laparoscopic sterilization, we can go as a Palmer approach also.
Okay. Okay. In this case, yeah. So you can go either subumbilical, umbilical, supraumbilical. We all know Palmer's point, Jane point, all these. But again, with this BMI of 40, it is better to go umbilical, because the depth from the skin to the fascia is less at the umbilicus. So it is better to go through umbilical. But the umbilicus is not always in the right position, right?
Yeah.
When there is a panniculus of fat, it is caudal, the umbilicus is shifted caudally. So sometimes it is not easy to go umbilical also. And somebody mentioned about the Palmer's point. Sometimes we think the Palmer's point is free of additions. Sometimes there could be additions. But then the reason Jane point is a good option in that case. And the other thing I wanted to mention is, yeah. Yeah. So you shift the umbilicus position, you shift it and then put in a Verus needle through intra-umbilical. So that is a better point.
And again, it depends on the cases, ma'am.
Definitely. So the entry techniques. So how would you enter? Now you are going intra-umbilical, but how would you go?
First of all, we have to use the Verus needle. Actually, we use Verus needle, and we through Verus needle we can enter the abdomen.
Sure. See, it is as we know there are various techniques, but I think in this case, Verus technique is the better technique. When you go directly Hassan, open Hassan, there's just, as I said, that's 8 to 10 centimeter fat to reach the fascia. So it is a bit hazardous. So it is not easy to reach by open Hassan technique. So it is always better to go Verus technique. Like how much ever I always prefer to go with the Verus needle. Only thing is, in this case, you need a long Verus needle like the 15 centimeter. And trocar also, you might need a long trocar. So always hold the panniculus like this. Put the umbilicus in the position and then put in a Verus needle. So and then trocar insertion. So how do you insert the trocar in this case?
Trocar, we have to go perpendicular though.
Exactly.
Because she is obese.
Yeah.
Anyway, we have to go perpendicular.
Exactly. So if you go 45 degree, you are going to track through the fascia. So it is always better to go, 90. So as I already mentioned, this is the case scenario. This, the umbilicus is shifted caudally. So you have to align the umbilicus position and then put in the varus needle or the trocar. This is how you're supposed to put it. So that's it. Actually, basically, I put in this case just to mention the difficulty in the entry. So I think that's it. Basically, we can go for the next case. Dr. Charmila, you want to add on something?
No, perfectly done, Jayamala. Please continue.
Thank you. This is case 2. Dr. Sumati will take over.
Hello, madam.
Hi, Sumati.
Hi, madam. Charmila, madam. Good evening.
Good
Thank
evening.
you,
Hi.
madam, for the nice introduction and giving us this opportunity. We'll go to the case 2. This is a 48-year-old Mrs. BK, BMA of 28, para 3, live 3, previous 3 cesarean sections. First was done by midline incision, second and third by phalansteal incision. She was complaining of severe menorrhagia with scan findings of multiple fibroid uterus up to 14 to 16 week size. All medical treatment failed, so she is now admitted for laparoscopic hysterectomy. So, Dr. Gayatri, what difficulties do you anticipate in laparoscopy in this particular case, seeing her past history?
First of all, because of her previous 3 cesarean sections with different incisions, one in the longitudinal and the other I definitely anticipate additions between the abdominal wall, omentum, and probably intestines up to the either the entire length of the uterus or sometimes even beyond it. The entire reproductive organs might be adherent to the anterior abdominal wall, as well as the multiple fibroids might have distorted the anatomy completely. So before planning for a lap hysterectomy, we need to do myoma mapping as well as proper imaging to understand whether the uterus is stuck to the anterior abdominal wall or to what all organs it is adherent to, as well as the bladder, whether it is pulled up. Also, mainly it is the adhesions and the distortion of the uterine cavity and the multiple, the additions to the bowel as well as to the bladder. That is going to decide the entry point.
Yeah,
and the difficulty level, of course.
Yeah, definitely, as Dr. Jayamala told, definitely entry point is the important point, primary point where we are going to do. So that is very, very important. As we know, like uterus is enlarged 14 to 16 week size. You always prefer just go 2 to 3 centimeter, maybe 2 inches, 1 inch above the uterine size, and preferably Palmer's point may be helpful. Primary port, you can put the umbilicus and see whether there is any addition. Then you go for the 10 mm port. So in this particular case, uterus was enlarged with multiple fibroids and it was stuck to the anterior abdominal wall with omental additions to the midline skull and also to the uterus. And obviously, when there is a uterus is stuck to the anterior wall, bladder also will be stuck to the anterior wall. And also to the uterus, so we have to be careful. So we have put the scope. The finding was like this. And thank you, Dr. Sri Sudha, Dr. Gayatri. What energy source you use, Dr. Vanitha Rukmani?
Good evening, madam. Thanks for the opportunity. Thank Umayal ma'am and Charmila ma'am, Amog Society, for the opportunity. In this case, since there are so many additions in the anterior abdominal wall, and as rightly said by Dr. Sunita madam, with scissors and with vessel sealer or ligaturizer.
No, additionalizers, no. Scissors is the best option because once you give traction and you can see the avascular area, you can nicely that get the cleavage plane, you can do it. And would you like to use any other energy source for additionalizers apart from this vessel sealer? You use the vessel sealer for additionalizers here, or any other source can you use?
Vessel sealer, yes, actually. Or scissor.
Lateral spread. Yeah, you can use no with
bipolar.
And let no, you have to keep the energy low level always, because you have to think of lateral spread always. Whatever energy source you use, it's very, very important to understand the energy source and how much of lateral spread, whether it's bipolar, monopolar, or vessel sealer or harmonic, whatever it is, you have to understand it, you have to study it and use that energy source as much as possible. When you are close to any organs, no, like bowel, bladder, always it's better to use the scissors, because non-energy instruments. So it's very, very important. You can use the harmonic here for additional lysis. No, that is more easier apart from scissors.
Can we use the harmonics, or even the ligaceous can be helpful for the addition lysis?
Yeah. So it is safe to use it. When you do it, you have to give some traction and then see the cleavage plan. And thank you, Dr. Anita. Dr. Selvarani, what are all the precautions and techniques while doing dissection in bladder and bowel?
Good evening, dear madams. Precautions like definitely we have to take care of the bladder side. So I'll just hold the bladder, the whole bladder with the non-toothed graspers, holding, and gently do the dissection by the scissors or by the harmonics. And I'll ask my anesthetist to give a deep head low position to avoid the bowels coming into it.
Anything else like a
metal catheter can be inserted and just see the extension of the bladder addition before going in for any kind of dissection.
We can use the lateral window technique. Instead of approaching the bladder from the center, we can always go from the lateral side, either right or left, as per the thickness of the additions, as we visualize during the scopy. We can approach the sharp dissection of the bladder from the lateral side at first, after opening the anterior leaflet of the broad ligament from the round ligament first, and then going slowly from the lateral side. That will avoid the injury to the central point.
Yes, madam. Exactly.
Pardon?
Lateral window technique is very good, and the use the scissors and tip of the scissors, that is fiber to fiber dissection is very important. It's the in your bladder, and also you can put the methylene blue dye also to see the when it's very important. So
rent is there.
You keep it in mind while dissecting the bladder, because it's very important. Even if you make the nick on the bladder, doesn't matter when you make a nick on the scissors. It's easy to repair. But if you use the energy sources there, it's a real difficulty, because energy sources, if you use, you will not understand, you will not know that injury on that point, and then it will manifest after 10 days.
Extent of the injury.
It's always better to use the scissors, tip of the scissors, fiber by fiber dissection, lateral window technique, and you can use the methylene blue. Even for bowel also, you just give traction and then cut. But how Sunita madam showed it very nicely, the bowel additional lysis. So if you do that, it's always better. And also you can put some saline also, hydro dissection. So when you put saline, you can see that additions in between two organ additions, you can see get the cleavage plane very easily. So you can go slowly. So it's very important. You have to be very slow and you have to be very careful. Once you put the scope, you just assess the whole abdomen and whole anatomy, even if it is the starting thing, and then go ahead. Thank you so much. What are the tips in multiple additional lysis? Dr. Kritika Devi, once we are doing multiple, it's all over, momental additions everywhere, throughout the abdomen and pelvis. Any tips, easily doing the multiple additional lysis? How do you do it? Do you do through the tenement scope, umbilical port, or would you any other technique?
And put in an additional lateral port.
Yes, yeah.
Additional lateral port can be for the bipolar.
Using a palmate point and then go laterally and cut the adhesions as close to the abdomen, anterior abdominal wall will help, ma'am.
Actually, the main thing is the traction and the counter traction part, ma'am, for the adhesiolysis.
Yeah,
So
that is true, exactly. Yeah.
yeah, that will give a
And
proper
then for the
No, everyone addition.
thin additions, as you said, you can use the sharp scissors, but you can change the scope from a 30-degree scope to the, 0-degree scope to the 30-degree scope also, depending on what organ you want to see and where you want to do the dissection.
Yes,
You can change the scope also to 30-degree scope in case of necessity, especially to see the posterior surface of the uterus, because the fibroids, the multiple fibroids would have distorted the anatomy. So by changing the scope as well as the instruments, namely the sharp dissection,
yes,
as well as by using bipolar to hold and cut the.
Yes, madam.
Pardon?
Pan adhesiolysis, what we do is, on 10 mm scope, you change it to 5 mm scope, 30-degree scope, and change the ports. You don't need to put the extra port because
Yes.
it's very difficult. Visibility will not be there. Accessibility will not be there. Your instrument should be perpendicular to that area. So we have to change the ports. Now, if you take the 5 mm 30-degree scope and keep changing right, left, right, and then you can easily do the adhesiolysis, but it takes time. You have to have patience, and patient safety is important. Thank you so much, madam. This is the thing. No, that was the case. I think you all can see this. This is the
Can I say something? Can I say something?
Yes, madam.
See, there are 3 scars there. So be very careful, and as you said, emphasized on sharp dissection is extremely important.
Yes.
Always sharp dissection. Do not pull, because sometimes you have had tears in the bladder when we try to pull it bluntly and try to push it also. The scar would have been so adherent, and when you try to push it like that, small injuries can happen which you will not even recognize even with your methylene blue, and after 6 weeks you'll come with a fistula. So it's always better that you do a sharp dissection. Remember that the uterine artery will be pulled up in 3 scars. You will not know, it will be like, there will be like an accessory vessel coming into the, almost like mid part of the bladder, and if you don't recognize that vessel, it's going to bleed heavily when you touch that. So it's always, you have to be, as you said, it has to be millimeter by millimeter. Every adhesion has to be taken care of with sharp dissection. And 3 scars, you have to be extremely important with the bladder. Most of the time, that is the area you will damage the
So another key point is, if see the additions is here, when you do the adhesiolysis, go away from the bowel, away from the bladder, and close to the, if it is to the anterior abdominal wall, always just to see, you have to to just go close to the anterior abdominal wall. Just see that cleavage plane and do. But if it is like if it is like this, if it is ventral suspension, what you do is you have to be close to the uterus. See what I am doing, close to the uterus. Once you use the harmonic, it will go away. And then as you go down, the bladder will be here. Again, you have to be very careful, close to the uterus. Don't go close to the anterior abdominal wall, you will enter into the bladder. So it is always better millimeter by millimeter dissection, and use the scissors when you go near the bladder and stick close to the uterus. And also see the always fat belongs to bladder. So see that also. That is important. That is the tip you have to follow. And also as madam said, this is the lateral window. In bladder dissection, you have to know after round ligament, if round ligament is cut, you can get this anterior leaf of broad ligament. You can go through it. You can see the lateral window you can create, and then you can just reflect the bladder down. By using the scissors or harmonic, you can do it. But monopolar hook also you can use, but I don't prefer here. I prefer in this case the scissors. It's very important because bladder is stuck to the uterus, and it's important to make sure that we don't give any energy injury to the bladder. So we'll go to the next case.
Case 3. He's a 34-year-old. This is ST. Actually, I operated this patient 2 weeks ago. He's a para 1 live 1. previous section 9 years ago. She was complaining of severe dysmenorrhea, dyspareunia, and painful defecation. She was diagnosed with bilateral endometriotic cyst, had laparoscopic drainage of endometriotic cyst due to extensive adhesions elsewhere. When she was supposed to have a bilateral cystectomy, she went for a laparoscopy surgery, and then the surgeon said that there are a lot of adhesions. She couldn't do anything, so she has just drained the endometriotic cyst. So 2 months later, she went to another hospital with same symptoms, and they tried to fit in a Mirena, but they couldn't fit in the Mirena. Again, she presents to you with above mentioned complaints. The ultrasound showed bilateral endometriotic cyst again. We have decided, like after counseling her, I thought Mirena, how can a Mirena can't be fitted? So it was done under sedation. So I told her like, we'll put in a Mirena under GA. But I have counseled her. Then she came and she said, Madam, as well, you do a laparoscopy and see what it is. And if it is necessary, you do a hysterectomy also. So I tried to put in a Mirena. I did a hysteroscopy. Actually, it was very difficult. A lot of false passages. I couldn't do a hysteroscopy, so I couldn't fit in Mirena. So I went up to do laparoscopy, and then we've decided to do a hysterectomy. So in such case, what you like? I mean, would you like to do any other investigations before surgery, and why, Dr. Kritika Devi?
Any other investigation before surgery?
Endometriosis.
Anybody can take
tuberculosis infection.
We can do an MRI to see whether how is the endometriotic cyst and adhesions level actually.
Excellent.
So the anatomy gonna get distorted. So we need to do one complete evaluation before.
Okay, excellect. So before that, yes, you need to do a thorough examination also, right? So the pelvic examination, actually there was no nodule. I did perectal examination also. There was no nodule except for the fixed retroverted uterus. The mobility was restricted. The MRI didn't show much. The MRI showed like 5 into 6 centimeter bilateral thick walled endometriotic cyst. Otherwise, there was no rectal ureteric involvement. It didn't give me anything else. Okay. And this patient, what are the extra precautions?
Extra precautions and planning for this is like usually it seems to be like a early frozen pelvis. So definitely we can go with the stenting of the ureters before proceeding with the hysterectomy. Then if it is safe to proceed with the lap hysterectomy, ma'am. And even the bladder dissections also, it will be helpful when we put the stenting on. If it is when the endometriotic cyst is very fixed to any of the sides, either one of the side of stenting will do. I think so, ma'am.
Better before we go for the surgery, we have to sit with the patient and attenders and discuss about the procedures, about the bowel and the bladder.
Yes, ma'am.
About the bowel and the bladder.
Bowel injury, yes, ma'am. Ureter injury.
And consent regarding the same.
And also we need to tell them like how we'll be able to, whether to complete the procedure, entire procedure, or whether we'll be able to proceed or not. There is always a chance for laparotomy if required. Everything, procedures have to be explained before we go on with the surgery.
Jayamala, you have to unmute yourself.
Yeah, sorry. As you rightly said, yeah, we have to involve multidisciplinary approach is a good thing. And then consent, getting consent, you should always get consent for laparotomy. But once you start doing complicated cases, you'll have high thresholds to convert to a laparotomy. And sometimes I get scared, like, because you're so used to the good visibility. If I have to open, I will think 1,000 times. I prefer to do laparoscopically, however difficult it is. But again, yes, converting is not failure.
Yeah, it is an expertise opinion. Like, how good are you in open? How good are you in lab? If we are comfortable in lab, we can proceed. If we are comfortable in open, we can proceed. But always tell that the attention with the attention, it is the expert in where we are. We have to go with that, not with
Exactly.
that.
Yeah, that's right.
Actually, we had a case with severe additions from endometriotic cyst. We were confused whether it was a CA ovary or it was an endometriotic cyst. So we couldn't do anything. We can open. We just opened the. We just entered the abdomen. It was looking like a CA ovary. After all the investigation, it was looking like a CA ovary. On table, we got an hello?
Tumor markers.
Tumor marker was high, ma'am. Usually endometriotic cyst, the tumor markers will be high, no, ma'am.
Yes. So CA125 be high, HE4.
Ma'am?
HE4.
No, in malignancy, it will be in thousands, but in an endometriosis, usually it's not in thousands, it will be in a few hundreds. Isn't it? Sometimes the malignant.
But we had a great doubt after going inside, ma'am. We got an oncologist
30,000, etc. But
many times these markers are not useful at all. No? They
Useful
will not
at all.
even tell you what is there.
And we sent a frozen and we got it as endometriosis. We closed it. I actually managed with Uprolite. The patient is doing good now, actually.
So yes, what are the steps to avoid ureteric injury?
Push the bladder.
Stenting of the uterus pre-operatively and
Identify
So we forgot to
and
stent.
go close to the uterus. Stenting, not always, ma'am. Like, we can push the bladder down, go close to the uterus as much as possible, avoid energy resources as much as possible.
close to the uterus.
But most of the times, endometriotic cyst or ureter is always involved with, repeated surgeries. Definitely there is fibrosis, there is adhesion. Most of the time the ureters are involved in these frozen pelvis. So you should be really very, very careful if you are not sure. And if, it's as you rightly said, stenting is not always necessary, but you can go with the lateral pelvic wall dissection, identify the ureter, trace the ureter, and be safe. So you always trace the ureter before you go ahead and do the dissection.
The fluorescent things.
Sorry, ma'am?
Yeah. Madam?
Or if you have the infrared illuminating system, yes.
No, Gayatri Madam was saying something.
No, the light tip ureteric stent, which she has already mentioned as the iris. That also, even if we had forgotten.
Yes.
No, so we can do an intraoperative cystoscopy and introduce that thing and proceed with the
yes.
Dissection nearby the ureter of the the ureteric tunnel, especially. That's where the adhesion is maximum, and we are very afraid of injuring that. So even if cystoscopy and an introduction is a good technique.
Yes. So actually, this is the case. Like when we went in, there was multiple fibroids also, and it is totally stuck. So yeah, that is the posterior aspect. The rectum was totally stuck there. I usually prefer to install vasopressin in these cases because there will be small oozes which obscure the field. So I put in vasopressin. Yeah. So went by the lateral window. Lateral pelvic wall dissection, and then identify the ureter. Ureter was totally adherent with the ovarian cyst. Luckily, on the other side, the right side, it was free. So, and then as Dr. Sumati just now mentioned, the lateral window technique for the bladder. Here, the anterior part was free, although she had a cesarean. I think it was done by me, so it was totally free. I didn't have any difficulty with the bladder. And then, yes, the bladder was totally taken off, separated. And then the right side, yes, it was free from the lateral pelvic wall. Yeah, and then here one tip I wanted to give is, previously I used to, whenever there is a bowel, I used to try to remove the bowel adhesions, rectal adhesions first. But now I have learned this technique where I finish off my hysterectomy, go for the colpotomy. And when I'm doing colpotomy, when I come to the posterior surface, I shave off the rectum from the uterus. And that seems to be not easy, if not a safe technique. So that is how I did. Of course, I called in my GE surgeon also, but this technique, I feel it is much safer. So that is what I wanted to highlight.
Safer.
Yeah. So that we had done it. I think the patient is very happy now. It has put a turmoil in the whole family. The whole family came and thanked that the patient. She used to say, every day when I have to defecate, it's like hell. But again, her clinical symptoms and her examination findings didn't correlate that much. But I went in, yes, this was the finding. I think once they drained the endometriotic cyst, at least they could have put her on GnRH or Dynagest, or at the same sitting, they could have put in a Mirena. But again, she wasn't given anything. 2 months later, she presented with similar, same complaints.
We need to put in a drain also,
How did that?
Whenever the level of difficulty is more, especially in dissecting the ureters or the rectum, even if you shave it off from the, joining of the uterosacral ligament from the serosa of the uterus, it's very important to put in a drain through one of the lateral ports. In fact, even 2 drains, so that you can sleep peacefully.
Yes, ma'am, rightly said. I forgot to mention that. It is always better to do a cystoscopy at the end also to confirm that the ureters are fine. In some scenario, this young lady, she's 34-year-old, we had done a hysterectomy, we had removed both the ovaries. Now, post-operative management, what do we do, Dr. Vanita? In the sense to prevent residual endometriosis.
We trust you, you've done a good surgery, so we will not think of residual endometriosis.
But still, I would prefer there could be microscopic deposits somewhere. I'd be too scared that you might get residual endometriosis. So I would prefer to give her
first 3 months, I think we can use a GnRH analog, as you said. Analog for the first 3 months, but not later, It will be completely drying up her vagina. So not...
See, when you've taken off the ovary, you should not worry so much about residual endometriosis, Jayamala. So, see, see, these drugs are also not very safe. You cannot give Leupride depots for a long period of time thinking that you will stop that. If it's going to happen, it's going to happen. So, I personally, if a good surgery has been done, will not try to do anything medically for thinking that endometriosis may happen again. That's my policy, because these drugs cannot be given for a long period of time, and how much these will help for the endometriotic tissue, which is in the rectal area or outside the pelvic area, we don't know how much it will help also. So, but tackle the menopause, because that you have to be very careful, because she's only 34 years old. But residual endometriosis, I'll take a call on that. I will not rush in and give a Leupride depose or tiny, just thinking that I will preempt recurrence of endometriosis.
So, what is your take on HRT in this woman while we are thinking about residual endometriosis?
See, not all land up with vasomotor symptoms, but to be careful for the bone and the heart. So that is the main thing. So it's worthwhile giving the low dose estrogen just to keep her on the safer side, but you have to be careful. That's why I know you talked about, but when you're giving a medical management of residual endometriosis, it's going to make her hypoestrogenic state still more worse. So there's no win-win situation there. So see the symptoms and then manage. And in the initial period of the surgery, I think it's better that you do not give any drugs for a period of time. At least for the bone and heart, because it will be there for some period of time. But when you do have FSH level, suppose it's rising, that means she's gone totally into menopause. That time, I think you should start HRT depending on her symptoms. Suppose it's going to be bone health, it's better to go for alendronate or any of the, only for the bone part, and keep a watch on the heart, because we never know like how we are going to aggravate an endometriosis when you're going to start from menopause also. To be very, you can go for the alternate, the SERMs, the loxifene, the tibolone, all that you go other than estrogen first shot. But if it's going to be very severe for menopausal symptoms, then you go for low dose estrogen.
Yeah, completely agree, ma'am. Like, yeah, lifestyle adjustments and dietary supplements, like flax seeds, sunflower seeds and all those. And so, yeah, all these we, tell them to take a healthy diet. And then, as you said, rightly said, alternative medicines. Yeah, that might help her to tackle her postmenopausal symptoms, menopausal symptoms. Thank you, my panelists. I think we'll move on to our next case.
Yeah, this is the last case we will discuss. She is a 33-year-old Mrs. KJ, Para1 Live 1 miscarriage, had on previous elective LSES. She conceived spontaneously 10 months after the laparoscopic myomectomy 4 years ago, and it was done by me. And then underwent elective section 3 years ago, again by me. And she had spontaneous miscarriage at 8 weeks 1 year ago. And just a year ago, follow-up scan and MRI showed few fibroids, that was type 5 fibroid near fundus, around 5 into 5 centimeters, and on broad ligament fibroid, no other symptoms. So hence laparoscopy was decided, because in the 6 months prior to this scan, the scan did not show any fibroids actually. So I just wanted to do the laparoscopy and see and remove the fibroids. So she wanted to try for next pregnancy also after this. So in this scenario, what do you expect in laparoscopy, Dr. Selvarani?
Ma'am, she's previous one cesarean, and she underwent a laparoscopic myomectomy also. Yes, ma'am. And when we proceed with the laparoscopy, we are encountering a broad ligament fibroid. There we gives suspicious of anatomy distortion of the ureter, and even the fibroid size is also more. So I'll definitely proceed with lateral window technique of approach, and even the which side of the broad ligament fibroid I wishes to go for stenting also, ma'am.
Okay, that's good. And any anyone else, any other?
Yes,
any other,
even if the broad ligament fibroid, we can inject some vasopressin also, ma'am.
Okay, yeah, that's fine.
To avoid bleeding.
Any other findings would you expect? Anyone can answer?
Actually, ureter will be distorted in a broad ligament fibroid. So we should be very careful in dissecting the broad ligament fibroid, ma'am. So I think we can do a stenting and we can go further for a broad ligament fibroid.
Yeah.
Why poster for a myomectomy, Smriti? She just had one abortion.
Fibroid, madam, type 5, she didn't have anything. It was no, like 6 months ago, there was no fibroid. Suddenly, there was some fibroid has grown. And I was just suspicious, no, that's why I put the laparoscope. So as everyone was thinking, I also thought that it was no fundal fibroid and this thing. So by seeing this picture, anyone can diagnose. See, this is the hysteroscopy. It is normal. Okay, this lady had, when I did the section, I removed one small mass, maybe 5 into 5 centimeter mass from the near the conception probably. This lady, same lady, that showed endometrial sinus nodal tumor, benign tumor. That's why she was on follow-up actually. So that's why if any fibroid recurs, I wanted to remove it, because there is a very small chance that endometrial sinus nodal tumor can turn into malignancy. So that is the reason she was on close follow-up. But this girl, again 2 fibroids, and MRI also showed only 2 fibroids. So I was on a suspicion to just look into the scope. That's why I did it. But see, her hysteroscope is normal, and anyone can see the pictures. I think you can see these pictures very clearly. Oh, sorry. Spot diagnosis. Sorry. Okay, very good. Yeah. So then you see this and see clearly. I will show here, 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 here.
Peritoneal
What is
fibroid.
that? Anyone? It's a spot diagnosis. I was very surprised to see after putting the scope. I was standing for 10 minutes without doing anything, assessing the whole
Ma'am, it's
abdominal
the
pelvis.
tubal
What is
hydrosalpingo.
it? No, fibroid everywhere. It's a parasitic fibroid.
Fibromatosis, something like everywhere.
Peritoneal
fibromatosis.
No, peritoneal. Yeah, this is a parasitic
Peritonealis, something.
We are long time since you have studied all that. Some youngster is there.
Peritonitis, intraperitoneal. This is the parasitic. Otherwise, it's called parasitic fibroids everywhere.
Parasitic.
It's
parasitic.
Fibroid, the small frog-level fibers. The thing is, even MRI missed all these other fibroids. There is one fibroid, fibroids in the anterior abdominal wall. In the sigmoid colon, it is there is a fibroid. And here anterior abdominal wall, right side, it's a quite big fibroid. That also MRI missed it. So that's why you can't just go by only radiological finding. You have to, when you put the scope in, you have to do 360-degree analysis and fibroid everywhere. It was very, so after 10 minutes, then I started removing one by one all the fibroids. And it was 12 fibroids varying from sizes from 0.5 to 6 centimeters. So I have to just ligate this fibroid near the sigmoid colon because I didn't want to use energy source. So I put use the suture material and ligated it and then cut it. And then this fibroid, anterior fundal fibroid, I removed, did the myomectomy and sutured it. And then the challenging was, it was one fibroid here. That was near the right side, near the ovarian fossa. It was very difficult to remove. It was over the ureter. I had to just remove and control the bleeding. So somehow I could remove all the fibroids, even small fibroids. It took a long time. And then patient is doing well on follow-up, no other fibroids. Why I put this cases, it's always important when you modulate, first laparoscopic myomectomy, I used the power modulator. I didn't do the in-bag modulation. That was the mistake I did. So that was spread out. So that's why tissue retrieval is very, very, very important. Whether it's ovarian cyst or fibroid, you have to be very careful. Mechanical modulation, power modulator, in-bag modulation. If you use the power modulator, it can be thrown, small pieces can be thrown out, thrown everywhere inside the abdomen. Even it can go and cause the liver injury. Liver also, there can be deposits. So it's very important. You have to be careful in modulation. If you use the power modulator, you have to do the in-bag modulation. Otherwise, if you don't have the in-bag, you are not confident in in-bag modulation, you have to do the mechanical modulation. You can do the mini laparotomy 2 to 3 centimeters and pull the fibroid, and then you can just do the mechanical modulation like that. Or if you are confident in colpotomy, you can remove through the colpotomy. Or if you're not confident, is the technical difficulties are nothing wrong in just opening it and taking the fibroids out without spilling everything, even ovarian cyst. So when you do the ovarian cyst, if it is a big, more than 10 centimeters cyst, Dr. Kartika Devi, what are all the precautions? How do you decide whether we can do through laparoscope or open surgery, which is best? And is it necessary only? Is it good only to do the laparoscopic surgeries, or you can convert it to laparotomy? With what findings you will do that?
I think Kritika is not there.
Kritika or anyone else? That's Shobana.
Madam.
Yeah.
She's asking about tissue retrieval, Shobana.
Yes, ma'am. Tissue retrieval.
Not that question I'm asking. In ovarian cyst, tissue retrieval.
Ma'am, we use actually, using putting the glove inside, or.
How will you decide whether it can be done through laparoscope or laparotomy?
Madam, we actually.
signs of malignancy are there, don't take it out.
Solid elements and through MRI, before MRI, we.
No.
Ma'am, so
any
if we
ma'am.
suspect anything, no ma'am, don't do anything.
If there are signs of malignancy, you've got peritoneal fluid, you've got ascites, you've got
Just
any
do biopsy and come out, ma'am.
Yeah.
After the report comes, you can go for an.
No, excrescences are there, don't touch it. That's going to cause problems. And if you think it's going to be malignancy and you think you're going to puncture, do not do a laparoscopy. Better you convert it to laparotomy, safer.
Yeah, definitely.
Ma'am, whether to prefer it is better not to do a laparotomy, no, ma'am.
No. When you think you cannot retrieve the tissue without damage, do not continue with your laparoscopy.
Yes. Even if
one more thing, no. See, there is especially in dermoid cyst, if it is sometimes would be diagnosed in a single ovary. But when we do a laparoscopy, sometimes it is a bilateral dermoid cyst. But the fear of retaining how much of the ovarian cortex could be left will be doubtful if you try to do a laparoscopic dermoid cyst excision, especially if it is bilateral. Then also, I mean, that is of course your limitation on the surgical expertise of the operator, depending on that.
Depends on the surgeon actually, if they can do it without much of damage to the cortex and avoid a bleeding as well as rupture of the cyst, they can go ahead and do it with the laparoscopy. But if your expertise is not there, do not do that and cause a chemical pain, because people may say, I've done a rupture of the dermoid cyst laparoscopy and nothing happened, but there are cases of chemical pain also. And I think Sumati is extremely lucky with this case that she got away with doing it again. If she had gone to some other surgeon, she would have been in a soup. Because they last who did the myomectomy before and did the morcellation, because 10 years since FDA has banned the morcellation.
She comes in because of me. That is
that's what I'm saying. You're very lucky that you didn't get a medico-legal case.
But how to take a large fibroid, ma'am? It is very difficult. We can finish the case.
No, in bag. If you're capable of doing in bag, do it in bag. Otherwise, do a colpotomy is also difficult for 10 centimeters. Very difficult to pull out such a big fibroid through a colpotomy incision also. So you have to be like.
Or you can do the mini laparotomy, bring the fibroid close to the incision. Peritoneum, and then you can slowly cut it and take it out. So that will not just spill the small pieces inside the abdomen like we do in power modulator. So we have to be very careful. And as Charna madam told, like this surgical expertise is very important in removing the ovarian, leaving the normal ovarian tissue. And always it's better to know, like if the very clear cyst, tumor markers normal, there is no septations, other solid elements, other scan findings or MRI findings so suggestive of malignancy, you can just do the decompression of the cyst and remove it through the 10 mm port. And while doing decompression, you can put the 5 mm scope and straight away the 5 mm trocar, you put it inside the cyst and then put the suction and then suck it out, so it won't get spilled. But if you have any symptom, tumor markers or any scan or MRI findings suggestive of malignancy, it's better to avoid laparoscopy. Laparoscopy is not the fancy. We all doing everything for the safety of the patient and recovery of the patient. It's better not to spread any cancer and upstage the cancer and give parasitic fibers. That is the message I just wanted to give in this presentation. And in-back morcellation is very good. So any other, Charla madam, would you like to give any other tips in this tissue retrieval?
First I wanted to applaud both of you. Very nice, done it so well in a short period of time. And very brave of you to present, Sumati. Very, very brave of you to present parasitic fibroids after a myomectomy, because the message has to go across that you cannot do power morcellation and think that it's not going to spread. If it drops, and even an ectopic, I would say put it in a bag and remove it. Don't try to pull it, because we have seen that minimal infection after even 6 months they come with that port infection. I don't know, like whether we saw because we pulled the tissue through that without bothering about the retrieval correctly, because sometimes in a hurry we just try to pull it as much as possible, cut it inside and do that. Put it in a bag and remove it, always safer, because those 1 or 2 patients come even after 6 months. I have one after delivery, again she has got a port infection now, endometriosis. So be very careful.
Put in a 5 mm scope and through the 10 mm trocar, just introduce that ectopic tissue into the trocar, and then you can pull out.
See, the main thing, don't spill any tissue inside, because that's the main.
It's very important how the technique you use. It should not get no spill. There should not be any spillage. That is very important. Since the time of parasitic fibers, I'm very, very careful in tissue retrieval. Very, very careful in that. And then, so that's what now I just wanted to pass the message. It's very rare parasitic fibers. If I had believed MRI finding, I just left it up. As Madam asked, why did you do the laparoscopy? Because of that endometrial nodal sinus tumor, I just always had in the mind whether she can have some sarcoma or thing. But to my surprise, no, after I put the laparoscope, I could see so many fibroids. My goodness, my heartbeat went up at that point. It was nice. Now, luckily, I did everything in the safe way, and then patient.
See, we did a laparoscopy 20 years back for an ovarian cyst. It came as borderline granulosa cell tumor because it didn't look like malignant also. So that 20 years back, we never bothered much. So we thought, okay, we did something and removed off. Every 10 years, she's landing up with a residual tumor. Till the time I'm alive, I'll see her every 10 years now. 25 years we did. She came in 2007 once, 2017 once. Now in 5 years, she's come again. So that's a granulosa cell. Borderline and
always headache, madam. I also had very bad experience where pathologists missed it. Borderline mucinous tumors. They behave very oddly, like it's very difficult to diagnose. And also sometimes they miss in the histology also. So we don't treat for further treatment will be, we cannot, we couldn't give. So a very bad experience in borderline ovarian tumors.
If any of my relatives do OG, I will hand over the patient to her before I retire. That's what is going to happen.
That's what I wanted to add on here. Like once you have suspicion of ovarian malignancy, it is better for us not to touch the patient first, not to convert to laparotomy. I would rather send the patient to a cancer center where her survival rate could be higher.
Much better. Yeah, definitely.
If it is dealt by a team.
There are so many advances now in oncology that we should not do that, as Jayamala said, because you give a better survival rate when an oncologist with a multidisciplinary team manages on them, because they're so good nowadays. Even stage 4, they're bringing them out, and the survival is almost like 4 to 5 years for many of them now. So I think that survival is very important. You can stop sharing, Sumati. Sumati, you can stop sharing it.
Yeah. So the last one, thank you, madam. Thank you so much.
So thank you. That was a wonderful
thank you, panel.
Thank you, moderator, ma'am.
Excellent moderation by Dr. Jayamala and excellent inputs from all the panelists. The icing on the cake is, of course, the expert, Dr. Charmila, dear friend, and wonderful discussions going on here. It was a pleasure listening to all of you. Thank you, all the Tamil Nadu dear friends. It's a pleasure to be with you. Thank you.
Thank you.
Over to you, Dr. Umayya. Yes, Anit.
Actually, so the previous chap was the top chairperson of Ramala Madam was not able to give her comments to network issues. So I like to invite Dr. Ramala Ma'am to give her comments on the talk on hysteroscopy by Sneha Viewer Madam.
Good evening to everybody who had participated in this program. My sincere and heartfelt thanks to Dr. Umayal who had organized this today's webinar. And it is not only sharing of knowledge or academic fees, but also it is very happy to see the friends from the Dr. Sneha and Dr. Anit, Sunita, all those friends we are able to see through this webinar. And their talk was very excellent. There is no comment to add on to that talk. But what is my opinion that all the PGs, before they finish their PGs and go for practice, they should be well trained in hysteroscopy, because hysteroscopy nowadays is a very it is not a very complicated procedure, and every obstetrician should have the hysteroscopic equipment, and they be able to do it by their own and not referring to others, because all small polyps and all those things we are able to manage. Even incomplete abortions, some doctors, they are removing it through the hysteroscope. So the anesthesia is not of much complication, because even through paracervical, we are able to do it with sedation. We are able to do it. Sometimes it may need to visualize, that is septum and all. We need hysteroscopy along with the laparoscopy. That is a very good procedure. So my sincere thanks and advance congratulations to Sneha. Thank you so much.
Thank you so much, Madam Amala Devi. Thank you for your blessings and best wishes. And thank you, all of you.
She's a Bhishmar. She's a Bhishmar, Sneha. Madam has encouraged so many of us, Dr. Amala ma'am. So her blessings will be very important for you.
Thank you so much.
Thank you, ma'am.
Thank you,
Thank
madam.
you, ma'am.
Thank you,
Best
ma'am.
wishes, Umayal madam. Best wishes.
Thank you so much for attending. I just want to announce that I am standing for election for the chair of Urogynec committee. So requesting all of you to bless me and support me and nominate me and help me to be there.
Yes.
ma'am.
So thank you so
All
much.
the best, Umayal ma'am. Thank you.
Dr. Shanti Rani,
Ma'am.
Madam Gayatri Nirgunj, and of course, Dr. Vanita, Dr. Kritika, all the faculties here. Thank you so much for your active participation. Looking forward for your active support, and please vote positively. And hope I deserve this position, and I request your wholehearted support. Thank you so much.
Thank you.
Thank you, Deja.
Good evening, Amala ma'am.
Thank you, madam.
Thank you very much, Dr.
Thank you
Jayama.
so much. Bye-bye.
Amala madam, bye.
Bye.
Amala madam,
Bye-bye.
thank you so much for joining. Romba nandri. Actually, like your presence here is making it even more authenticated. Thank you so much, and thank you everybody.
Thank you, ma'am. Thank you so much for the opportunity, ma'am.
Jayamala, Gayatri, everybody, every single person, and all the wonderful panelists. Today the panel was very amazing. Just one day of preparation, and the panel was where a level.
I think, yes.
Very interesting.
Only 2 hours we spent, our cases.
Time ponade theriyala. It is the 2 hours spent. No, like we didn't realize those 2 hours went by. And thank you
The
so much.
case was also very tough, especially the last one.
Last case was very interesting.
And Dr. Umayal, both the moderators did not even tell what it is going to be.
Yes,
ma'am.
That's completely extempore, I wanted to tell you.
ரொம்ப நல்லா இருந்தது. அதனால தான் ரொம்ப நல்லா இருந்தது. We got different.
We just didn't come prepared at all. We were just going to answer whatever comes to our mind at that point of time.
I think that's why it was the best. It came as extempore, your experience.
That is
best,
what we were discussing
Yes.
yesterday with Dr. Jayamala. We told everybody has started to take up laparoscopy. So we are all doing laparoscopy, and we all encounter issues. So let us go with the common issues, what we come across, and where we want to stop and think. So that's all we discussed. But today when I saw the cases, they were all very, very interesting, and a lot of take-home points. So,
Thank you, ma'am.
Thank you. Thank you.
Thank you so much. Thank you.
Bye. Thank you very much, ma'am.
Bye.
Thank you,
Thank you
person.
so
I'm
much.
seeing Dr. Anil. All the best. Thank you, doctor. Thank you. Thank you, ma'am.
Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye.